morning that's going to be kicking us off. And let me get screen shared. There we go. Okay, and kick off her presentation here.
And I just have to hit the arrow key,
Mm-hmm.
correct?
Mm-hmm. Yep, just got the arrow key.
Grab your stuff.
Morning, everybody.
Good morning. I wanted to bring you all up to date on our hospital-acquired conditions and show you a new product as well. So nationally, about almost 2 million hospital-acquired infections per year, and about 100,000 people die. So you can all read this, the 1 in 31 patients, but these are the things that we have here that might impact our patients. Falls with injuries, prosthetic devices like hips and knees, infectious endocarditis, which we would ship out. But realistically, the overall cost is about, well, it's several billion. Think what we could do with that. So in Arizona, though, surgical site infections lead the pack. And then urinary tract infections, SUTIs and CAUTIs. A SUTI is a symptomatic UTI. That is something that we do have more than I would like. We've had probably 4 in 2025. CAUTIs, though, we're doing great. Pneumonia, we haven't had one of those, knock on wood, in a long time. And our bloodstream infections, central lines and PICS. Because of the interventions that we do, knock on wood, we've not had a central line or a PIC infection of any kind. So let's talk about other organisms. This one that you see in the slide is C. diff. That's what it looks like in somebody's, and MRSA, of course, and then vancomycin enterococcus. We have had a couple of MRSA that came in that were in wounds. Y'all did really well isolating them, as you should, for wounds. So these are the things that we have here. So we have staph epidermis. Staph epidermis is usually a contaminant. It can come from medical devices, and it often has to do with blood cultures, which I know y'all don't do on the floor, but blood culture collection where the skin is not prepared adequately. The worst thing, though, is our hands. As we go through the day, they form a sticky biofilm. That's why we're always on you about wash your hands, wash your hands, wash your hands, because the friction helps break up that biofilm. And then we have quite a significant amount of Enterococcus faecalis. I always butcher that. It is normal flora. We all have it, but it is highly resistant to many antibiotics, and it's often caused by poor dentition. So our folks come in and they have poor dentition, and then, you know, they blow their nose, they don't wash their hands. That's why it's so important, but for meals, that you all give them their Sani wipe so that they can wipe their hands off so they're not infecting themselves. So these are the places that we have the most issues. Urine. I already talked about staph epidermis and Enterococcus faecalis. They are both attracted to Foley catheters. You guys have done a superb job of encouraging physicians to take out catheters as soon as they can. And so that's one of the reasons we have very low CAUTI infections. Changing wound dressings, you need to follow infection prevention practices. You go in, you wash your hands, you put your gloves on, you take off the old dressing, you take your gloves off and you wash your hands again. A lot of people don't do that, but it's really super important that you do that. Remember, gloves are to protect us, but they're also to protect the patient, but they do not substitute for hand hygiene. So the one thing that we did have this year, we did have a bloodstream infection, but it was from a peripheral IV site. This goes back to patients can infect themselves. Let's be honest, not everybody cleans themselves the same way. And I can't emphasize enough how important it is to give patients the sandy wipe that's on their tray. That might be the only time all day long that they clean their hands. Because if they go into the bathroom by themselves, chances are they don't wash their hands when they come out. So these are the kind of things that are on our hands. Staph epidermis, staph aureus, which is, MRSA, or just regular staph, E. coli out of your bowel, salmonella, norovirus, MRSA, VRE. These are things that are on our hands, and they are also on our patients. So these are the things you can do. Obviously, wash your hands, use PPE appropriately so that you're not passing things between patients. And foam works well. There are plenty of foam dispensers in your unit, so please use them. Foam in, foam out. So these are things patients can do. They need to wash their hands, and I know it's not really. We obviously were not designed by nurses because the sinks aren't really convenient. But they can wash themselves. We have the purple wipes. They can use them themselves, brush their teeth, and once again, sandy wipes. So beds are disgusting, and patients, let's be honest, even if you put a checks down, sometimes their butts touching the bed. Their hands touch the bed. They put Kleenex in the sheets. They leak various body fluids. Handrails, super, super germy. And while EVS does a fine job, we can't always just depend on them to do it. There's nothing the matter with taking in wipes to clean off somebody's overbed table before you set down their medicine cup. There are lots of ways that we can protect our patients. So these are the things that are on beds. Once again, MRSA, E. coli, Acetobacter baumannii, and this one is antibiotic resistant. We've had a couple here. Pseudomonas aeruginosa, also we have that frequently, and Klebsiella pneumoniae. And they can all be in respiratory secretions. They can be in urine. They can be in wounds. So daily bed changes. Getting your patients up for meals is super important. We all know that when people come in, they're sick or they wouldn't be here. But as nurses, we want to move them towards being independent and not think of themselves as patients. Well, I don't know about you, but I don't eat in bed. So our patients shouldn't eat in bed either. We need to get them back into the I'm a grown-up, I can do this, I'm capable. It also is the perfect time to change the bedding. And every day we should be helping our patients either shower or do personal grooming, including washing up the sink or the bedside table. And you really should coordinate with rehab services staff members, because if OT is on the case, they often are the ones helping people be independent, and they'll take care of giving them showers. So tell me what's wrong with this picture. Well, this man is out walking around the halls, which is great and it's fabulous. And now he's in his bed with the same socks on. Once again, I don't know about you, but I don't wear my shoes to bed. I also don't wear socks to bed. That's personal choice. If you want, I mean, it's fine for patients to walk in their socks if they're the safety socks, but either take their socks off or put another pair over those so that when they get back into bed, their socks are clean. So these are the choices. These are the people that need a daily bath of some kind. So any patients with a central line, including PICS, and surgical patients for 5 days post-op, all negative pressure wound therapy VAC patients, any wound care patients, all ICU patients. So you can do these with the CHG pack, or you can do it in the shower with the liquid. If you use liquid and they don't use it all up, you need to date when it was opened and make sure it's only one patient use. So here's some other things that we need to pay attention to. So heel pressure ulcers. We had a couple around the holidays. Heel pressure ulcers can evolve super quickly into stage 3 or 4 pressure ulcers. I know that Keenan and others are looking at better ways to help prevent heel pressure ulcers with equipment. If any of you are interested or have suggestions, you can talk to Keenan. So we do have the Optifoam Gentle Heel. They're silicone faced. They work really well. You can put them on the heel, and then you can also put socks over them so that they stay in place. Braden scale is kind of your roadmap. So if somebody has, like a 11 or 12, you might want to consider putting the foam heel protector on. Sacral pressure ulcers. We've had a couple of those. Well, they can evolve. Oh, excuse me. They can evolve fairly quickly. The real issue is that if you get a sacral pressure ulcer, because there's very little tissue there, and it goes down to the bone fairly quickly. That's why it's so important. And guys, as I said, seem to be doing a really great job. Patients need to be moved. You got to flip them side to side. You have to help them reposition. I know that we're looking at some positioning tools as well to give you the tools you need. As I sit here and tell you, no, you need to do this. Well, if you don't have the tools, but we're working on that. We do have the sacral wound, the heart-shaped, and sacral wounds, as I said, can evolve quickly to stage 3 or 4. Hopefully none of you have ever seen one of those, but they can be devastating to the person. They can lead to osteomyelitis. And some of our folks are so debilitated, it wouldn't take long for them to get a sacral wound. So this is this is a J tube. And we have new equipment for that. I don't know if any of you have seen this. I have one here, but I don't think you can see it. These are for J tubes. They're for chest tubes. You can use them for PICCs. They're compatible with 6 to 42 French sizes. They are silicone. They're very gentle on the skin. This will replace the safety pin to the gown that many of us grew up as baby nurses. That's what we used to use, and tape. So you won't have to do that anymore. J tubes, if they are left to hang and aren't emptied frequently enough, they can create a horrible fistula that takes many surgeries and months to heal. So catheter-associated UTIs, you guys, as I said, you are doing a fabulous job. It is obvious that you are cleaning your catheters correctly. And as I said earlier, you're encouraging physicians to remove them as quickly as is safe. So SUDIs are difficult for us to prevent because many women are unable to wipe from front to back. So they try the going between the legs and pushing that way, front to back, and then dropping the toilet paper in the toilet. But in the meantime, they pull back the toilet tissue and often infect themselves. It is important that we encourage patients how to clean themselves correctly. And I will be honest, the symptomatic UTIs that we have had this year, or in 25, were swing bed patients. And while we want them to be independent, and it's important for them to be independent, we still need to help them learn how to clean themselves so that they don't reinfect themselves. So patient falls, you guys do a good job too. We haven't had a ton of falls with injury. You're using your battle arms effectively and helping patients know their limitations. So here's some takeaways. Up to 70% of hospital-acquired conditions are preventable. It's team sport. Patients can be part of the prevention solution too. So make them your teammate so that they can be participants in their care. Evidence is very clear that if patients are allowed and encouraged to participate, there are far fewer injuries of any kind. And but here's what I really want you to know. You guys are so far ahead of the game. You really have stepped up and are making it safe for our patients, and our hospital truly on hospital-acquired conditions does a wonderful job. Do you have any questions for me? Thank you for your time. I'm out of here. You.
Make sure everybody's still here okay and everything?
Yep. Yes, thank
Yep.
you.
Thank you. And nobody has any questions for Trish before she bounces? Any questions on Foley's? Any questions on CHG bathing? Just a couple of things off of where Trish was coming from that I'd like to highlight. And she kind of ended that on a good note as far as we're doing a really good job on keeping these numbers down on these infections. And of course, it's still prudent that we have her come in and do a presentation on this stuff, even if we are, exceeding our goals as far as, healthcare acquired infections go. We still want to make sure that we're continuing to get that information out, the basics from hand hygiene to, if a patient has a Foley, let's get the Foley out, to ensuring that we have the proper, fall prevention items in place, that the steps that we're taking when we're, performing wound care or CHG bathing on patients, that those are getting completed appropriately. This is just so that we continue to ensure that we're maintaining that level of education that we have when it comes to infection prevention stuff. It's prudent. It's easy tasks that we can complete on a day-to-day basis for our patients to ensure that we're doing what we're supposed to do as good stewards of our positions in the hospital, to ensure that we're taking good quality care of these patients on a day-to-day basis. So continue ensure you're utilizing those practices that have led to the successful state that we currently exist in our department. So, encouraging the hand hygiene, encouraging and overseeing when possible, as far as wound care that's being provided, especially when we add new members to the team, just ensuring that the steps that they're following are in line with what the standard is for our facility. Ensuring that we share with, new additions to the crew, the standards that we have set for CHG bathing, and that, as we covered in the past, there's not just the wipes available. We also have the solution available so that they can, take it with the CHG solution instead of, just wiping them down with the wipes. I definitely want to give a huge shout out. I've seen some significant improvement in our tech team over the last, I would say, probably last 1 to 2 months, insofar as every single shift that I have covered as charge and have gone and rounded on patients, I'm finding that the patients are consistently up out of bed, in their chairs, ready to eat. So I know this has been one of those practices that we've been trying to really get moving in the right direction for some time, and I've noticed it's a significant improvement. When I do go around and complete rounds, I'm finding that patients are pretty consistently up out of bed in chairs. So between the day and night crew, thank you for making that happen. Night crews especially, because when I have gone through and asked, that's typically the answer I get is that night crews are getting these patients up to the chairs. So keep that going. That's the standard of practice that we want to have in place, is first thing in the morning, any and every able-bodied person that is able to get out of that bed, that we make those concerted efforts to get them out of that bed. At a minimum, getting them out of bed is going to help prevent pressure ulcer formation. That can still happen in the chair while they're up in the chair too. But it's a lot less likely versus them, just hanging out in the bed for days on end while they're here in the hospital. So keep up the good work on that. It is noticeable. It does have a positive impact on the patients. It has a positive impact on your staff members. It makes everybody's job easier when we follow those basic requirements in the department. Cheryl.
Yeah, that being said, 37 has been complaining that he has been in the chair all day for at least 12 hours and his bottom's been hurting. And we've been talking about trying to get him in bed, maybe on his side for some time during the day, maybe once or twice to get him off his bottom. So he does have what looks to be possibly a stage 2 on his coccyx. So, I mean, I know we want him up all day, but in his case, I think we need to take a look at how we can make an exception to get him off that coccyx for some time during the day to relieve that pressure.
So key things to keep in mind too, any stagnation in one position is going to lead to long-term problems for a patient. When I first started out in healthcare, I took care of a paraplegic, basically from the chest nipple line down. The guy didn't have any movement of his legs or his lower torso. So getting him to shift in that wheelchair intermittently throughout the day to prevent exactly what Cheryl's describing was challenging. When I first started out caring for the guy, I would have to, do a behind the back, grab both of the arms, lift, and kind of side just to kind of move the weight around. So same concept for patients that are up in chairs. They do still need to move and adjust, right? The human body is not intended to be stationary for long periods of time, whether laying down or sitting down. So it's just that sitting is favorable versus laying in bed all day. There is less risk for pressure ulcers because you're now eliminating the risk for the back of the heels, the risk for the back of the elbows, the risk for the back of the head. But of course, now that pressure is consigned to the coccyx or sacral area of the patient. So it is still critical whether we're getting him up and down into the bed intermittently throughout the day. And this goes for any patient, right? Or ensuring that he's getting good opportunities or other patients are getting good opportunities to get up and ambulate is another option there. But at a minimum, we should still be doing what we can to shift the guy around in the chair if he can't do it himself, right? That's the key is if they can't do it themselves, that we're teaching them kind of how to shift butt cheeks, so that they're resting not on the same spot for the amount of time that they're sitting in that chair. Um, Beyond that, obviously there is the recline function on most of these chairs as well. Majority of them will lay all the way back flat, so that can help to readjust some of the pressure for the patient as well. And then, of course, like Cheryl recommended as well, there is nothing wrong with getting them back into bed. The challenge is I'm not sure if this gentleman's a swing patient or not. Part of the reason why we want them up is so that they can remain active. And this is one of the things we particularly see on day shift is when we, do land somebody back in bed, it's a lot more likely for them to spend the rest of the day in that bed. So we do the best we can to avoid getting patients back in bed because, they will consequentially end up taking a 2 or 3 hour nap, sometimes sleeping through their lunch period, and then wanting to remain in that bed for the rest of the day. So get creative with the solutions that you come up with. And really the bigger key there is just make sure that we're continuing the movement for these folks as much as we can, even if it's, just popping your head in and saying, okay, hey, don't forget it's time for you to shift to your left butt cheek off of your right butt cheek, if they're able to do it on their own or assist them with that if they're not able to do it on their own. Before we move on, I'll take a quick pause if anybody has any questions, suggestions, things that they've tried that works pretty well.
Keenan, one thing I've seen in facilities is something called a Roho cushion. I'm not sure if anybody's familiar with that, but it's kind of like an egg crate on steroids. You blow it up actually, and it sits in the chair so that it protects their bottom because that way, sometimes those chairs are really hard after a while, but those Rohos are really good because it's like I said, an egg crate that they're sitting on. So it's redistributing the weight while they're sitting there. I haven't seen those at our facility yet, but another thing is that sometimes I'll just put a pillow underneath them and that seems to help as well. You have to watch it because sometimes they'll slide out from under it, but those are just a couple suggestions.
Okay, I've got this. I've got this looked up right here, Tristan. I'll after our meeting today, I'll do a little bit more research on these and see what we can do. If there's a reasonable means that we can acquire some of these. I also need to figure out too. They're kind of funky looking. They've got like they look like a bunch of balloons filled up.
Yeah, they're pretty
Once you
amazing.
take
And they also have a way that you can pull the patient up in the chair with straps with them. So
okay.
they facilitate, moving the patient in the chair as well, which is something that's a challenge if they're a large patient.
From what you've seen, are these typically one patient use, or are these typically shared amongst the department?
The ones I've seen are shared. They're not disposable. You can, once the patient uses
Clean them and
them,
reuse them.
yes.
Okay. Okay.
Yeah,
It's a little easier for me to justify, because just looking at some of the costs that I'm
right,
seeing is,
right,
pretty much anywhere between 100 and 500 bucks, just off the cusp.
right,
But if it's something reusable, then it's a lot to justify making the purchase. Then it's just a matter of finding a place that we can keep and hang something like that, and then get the cleaning protocol, whatever that may be, so that way we have something additional for when we do run into those patients that aren't able to adjust themselves in the
right.
chair, get up, move, which we see a decent amount of that. So okay, thank you. I'll do
Hmm.
some research on these, figure out a little bit more on them. Um, some department updates. Um, we have kind of seen this consistent trend of about 1 to 2 falls a month going on for the last couple of months now. Consistently, what I've been seeing is that these traditionally, as they usually do, falls on confused patients or altered patients that this is happening with. Um, and kind of the key here is just ensuring that we're utilizing our bed alarms. So when I was walking through the department yesterday, it was noted. I know 140 is one of our bed alarm patients. Hers was on throughout the day, and it had gone off a couple of times. I know that they're annoying. I know that they can drive people a little crazy, but it is one of the easiest ways. We may still not get in there fast enough, right, with that bed alarm going off, but at least we have an indication, and we can get there sooner to potentially prevent a fall from happening, at a minimum. And even if we're coming in the room as the patient's falling, at least we're right there, and we're not finding this person maybe a half hour later, 45 minutes later, when they finally start kind of calling out, laying on the floor because they can't get up. So definitely want to ensure that we're utilizing that kind of full package that we have for these fall risk patients, with the bed alarm being the number one item. Historically, bed alarms have been trended as not necessarily kind of preventative, but also not preventative. Obviously, if you wanted to completely prevent somebody from falling out of a bed, you would, secure them to that bed, restrain them to that bed, which we also want to avoid, the use of restraints as much as we can. But at the same time, it gives us kind of that early warning indicator, so that we can get down there to that patient to prevent the fall from happening. So what I can say positive is, for those falls that we have had occurring, we haven't run into any like major injury to the patients. So no broken bones, no cracked heads, nothing crazy like that. The majority of the time, these patients end up on the floor, and they maybe have a small skin tear or a scuff or something like that. So we've been very lucky with what we've been kind of the outcomes on these falls. But it's just a matter of time before one of these patients ends up falling and breaking a hip, or if they're already a hip patient, they dislocate that hip, or something catastrophic happens. I don't want any person on this team for that to happen to them, and then carry the weight and shame of that occurring, during one of your shifts, that your patient fell and broke their hip, and it is now having to go for surgery. So just bear in mind when you're going through and you're evaluating these patients for risk for falls, that you do take it seriously, and you get it as well set up as you possibly can to prevent that fall. The way that the pendulum has swung in healthcare, especially for the swing bed patients, kind of patients have quote unquote a right to fall, right? But that doesn't mean that we can't take every step that we can to help prevent it. And I will say this from a documentation and legal standpoint, it's going to look um, it's going to look a lot better, right, for the staff and for the team, if all of those preventative measures have been put in place and a fall occurs than if they haven't, right? Especially when, from a legal position, a lawyer would be looking at that going, well, did you follow the standard protocol that you have for your facility? And as soon as they find out that one of the steps was skipped, right, they're going to eat that person alive, right, for not ensuring that those steps were followed. So it's critical that you follow guidelines on that you follow the guidelines on bed alarms and other fall prevention items. Um, Questions on falls, questions on fall prevention, things of that nature. Suggestions, things that you've seen, other things you've seen in other facilities.
Yesterday we were looking to put a chair alarm on someone, and it took us about 10 minutes to find one, Keenan, because there were none in the drawer. Another thing that I've seen that works well is when they are actually secured, one for every chair in every room, and they're secured to that back handle so that when you go to get a chair alarm, it's right there to use. You don't have to go look for it or go wash one or clean one or whatever. But because it's already secured to that back handle, all you got to do is grab the tab and attach it to the patient.
You're talking about the actual like alarm box.
Right. The actual alarm box is like secured to that back handle. So there's a
Okay.
chair alarm for every chair in each patient room. So when you go to use it, it's there already. And, it hasn't just been picked up and, moved to it wherever. So you're not going searching for it. It's right there when you want to use it because it's secured to the back handle of the chair.
What happened to all the mats we had? Because those work so much better.
What are you referring to, Cheryl?
Well, the ones she's talking about are the ones with the little magnet to the box, which they fall off all the time and so they go off all the time just when they move. But the mats, they were like a mat that fit underneath, say like on top of the chair, and then they sit on top of it. We had quite a few of those. I know even when I started a couple years back, and now it's like they're just gone.
We will take a look and see what kind we have, and if we need to get some more, because I think those are like similar to the bed alarms that are used in the beds. They're pressure based, so
Yes,
like as soon as somebody
yes.
starts getting up
Like
off
the
of it, that's when an
Yeah,
alarm.
like the ones we had at Haven.
Okay, yeah, I'll take a look and see what kind we have, and if we need to order the mat based ones versus the old school magnet based ones, because I'm assuming the
Mhm.
magnet based ones is like you clip it to the patient, like
Yeah,
to their gown or something, and then when they go to get up, it pulls on it and disconnects the magnet, which of
yeah,
course is why we're getting the alarms when they're moving in the chair moving. Okay.
yeah. In fact, Anna and I
Okay.
were talking about it last night or early this morning, so I'm glad it came up today.
Okay. Anything else on falls? Anything on the new IV pumps? Has anybody run into any issues, any suggestions, do you like them? Do you not like them? I'm going to take silence as it's going well.
It
Probably.
went well last night. I think the only thing we had a problem with was 48, and Carlito thinks it's because the cannula is kind of like up against the vein wall, so even if she just slightly moves her arm positionally the wrong way, the alarm goes off, and it was annoying her all night. But other than that, everything's working fine.
Okay. I
If the
understand. Go ahead, Tim.
if the vein is up against the wall, there is a way of adjusting the pressure, the amount of pressure that's coming out of the IV to keep it open. Actually, it was a question that I asked the other day when they were training us. So, and he said he had not been asked that question, but there is a way to up the amount of pressure. So if someone's got a pick line or they've got a central line, that is kind of sluggish, you can up the amount of pressure to be able to infuse without it constantly alarming.
Okay, that answers that question for me because I was wondering in what scenarios you would use that because I did see that feature and no, but we just didn't know because it was, it was just us. It wasn't in the training.
Yeah, there's kind of the finer points of adjustments that you can make on these pumps. I actually, until Tammy brought it up, it's something that I forgot that existed on these. It's a nifty way that when you have IVs that are, good IVs, they still pull back blood. They still are doing what they're supposed to be doing. They're still infusing medications, but, maybe it's sitting in the AC and they kink their arm, they're getting an occlusion, alarm. Like Tammy said, and I have not adjusted that feature on one of these pumps in some time. So please, if there are especially if our team leads know how to make that adjustment, please get with them and have them show you what that looks like as far as making that adjustment. This is one of those kind of fine-tune adjustments that these pumps have available that are old ones, that wasn't even remotely a feature that was available in our old pumps. So just something that's kind of an extra little that's tacked on with these Alaris pumps that gives you a little bit more flexibility. Other brief update on the Alaris pumps. There are still some other medication modifications that Omar is working on to add more concentrations of meds into the pump. I know that one of the ones that isn't completely built out right now is the vancomycin drip. I want to say it currently has the 1,000 set up in there, but I believe it's missing the 1,500 and 2,000 for Venco. So then the staff is having to manually make those adjustments and add those numbers in. So if you run into other medications as you're going through and hanging meds that are not popping up in the pump, please get a message over to the pharmacy team as soon as you can. That way they can look into those and get them built out. We want this to be as easy as possible. We want you guys to be able to set up and run a drip, in a matter of 3 to 5 button presses instead of it being like 16 button presses because you're trying to add all the numbers in for the drip that you're trying to do and all that. So if you run into meds that aren't pre-built in there, pop a message over to pharmacy so that way they can look into it and get it built out for us. Voceras are around the corner. They actually just had the Vocera rep come out last week and meet with middle management folks. So that is all horizon. As we get closer, I'll have more information to share with you guys, but we're looking at somewhere in April or May to start rolling out the addition of Voceras to the departments. Just another nifty communication tool. So, and it makes it, the whole point of that is we eliminate these walkie-talkies that we've been using since I started here, and we move over to a more closed loop communication system where you can actually call staff members directly using Sarah. So, if you've got somebody running back to the ICU to grab something, instead of you having to now leave whatever patient room you're in, walk to the desk or walk back to the ICU, to talk to that person, you can just call them, anywhere they are in, the hospital to get a hold of them. And I mean, it's even, being able to call directly to the ED from, whatever room that you're standing in, just kind of nifty little tools and features that these devices have to improve our overall communication in the department. And again, this is all going towards the goal of getting us back to the bedside. Whatever tools that we can place, new IV pumps, Voceras. I'm looking at getting some smart vital signs machine rolled out for our team. Denise is looking into upgrading our glucose testing strip machines so that way we can upload directly into the charting system. So any which way that we can that's going to improve the efficiency and function of our team is kind of our goal and focus for this year. So these things will, they're going to take the better part of the year to roll everything out that we have on our goal list, right? But we're making incremental movement in that direction so that we can improve our overall teamwork and efficiency, which in turn is going to improve our patient, quality of our patient care too. So just be on the lookout. I'll be continuing to provide you guys with these updates as we continue to introduce these items for our teams. Just briefly, we went over code blues and code strongs in the emergency department last time. Just making sure that I know that we're already responding to code blues over in the ED when those are called overhead. Please continue to do so. But same thing goes for code strongs in the emergency department. Oftentimes the ED, specifically during the busy season, and this is about to let up, and we're going to cover that in just a minute too, right? But in the busy season, they don't always necessarily have a staff member that can step out to the lobby to go check and see if there's somebody waiting in a car that needs help getting out, right? And just because we may go walking down there and, let's say there's already 5 people out there trying to help, we can just turn around and walk back to where our unit is. So it's just to help lend that additional helping hand to the ED when they call overhead. And this is typically the registration staff that's calling, right? To ask for assistance. And it's usually getting somebody out of a vehicle into a wheelchair and bringing them inside is the most common occurrence here. So if we're consistently able to send 2 staff members from our department over to the ED when one of these code strongs is called overhead, it's just that extra little helping hand. You get down there and there's already people, turn around and leave. If there's not, you can at least get the process started in assisting in getting this patient out of the vehicle. And especially if the patient's in really bad shape, whether wounded or, critically ill, you can initiate that spin up on, hey, this is a little bit more than just a code strong, right? We're on the cusp of a code blue maybe, or a rapid response, right? We need to get this person out of the vehicle now, and by having those healthcare trained eyes on the situation, we're able to quickly identify that, to kind of get that person out of the vehicle and back into the back of the ED as soon as possible so they could start getting treated. Incident reports, key thing on these, same as always, we just have to make sure that we're consistently getting this stuff added into the system and logged. Anytime we have an unexpected change with the patient, whether that be a fall, a pressure injury, any kind of healthcare acquired infection, security issues of any kind, and this is a big one. We are as an admin team are hammering the security issue hard consistently. Every single meeting that we have an opportunity to speak about security, we are bringing it up as a topic. The more evidence that we're able to bring to that conversation when we have those conversations with board members, when we have those conversations with the C-suite, that we're able to say, look, we had 6 incidents in the emergency department and 4 incidents in the med surg unit within the last month that were security issue related. We want to make sure that we're getting those documented as much as we can so we can prove, right, exactly what it is that's going on in these areas, right? So please, when you run into those security issues, right, even I believe it was last week, we had a patient that we were highly suspect that somebody was bringing in some kind of drugs for the patient. We labeled the room, no visitors, whatnot. That is exactly something that we want to get down onto the incident report as a security situation, right, that we can share with the board members and with the C-suite so that they clearly understand the full picture of how important it would be and how helpful it would be for us to add security to the hospital, especially during our night shift hours, right, that are able to go around and ensure that people's vehicles are secure, that entry and exit doors are secure, and to assist in the emergency department when they have irate individuals that are doing unapproved things, right, in their areas. So please take those opportunities when these issues occur, document information in as objective as in a fashion as possible, right? Just the facts. What time? Where did it happen? What did the patient do? What did you do? You don't need to necessarily include anything in there about, I was so scared I pissed my pants, or, I was so scared I went and, hid in a closet, or, anything like that. I mean, actually, if you had to go hide in a closet, that you do want to include. But you know, it needs to be as objective as possible so that, the true happenings of the situation can be clearly conveyed, right? And if you're not sure how to write that up, bring it to your charge nurse. Trust me, they know how to articulate that information. They don't need to be doing it for you, but they can help guide you on what you need to type in order to convey the message appropriately. Talked with the charge nurses yesterday. I have kind of consistently been going through 3 to 4 days a week and modifying work lists. You guys have probably noticed that on some of those work lists, I've added in Q shift for the ADLs section. For others, I've added in Q4 hours. It's sounding like kind of across the board that folks are not necessarily caring for the Q1 hour, and they're not necessarily excited about the Q shift because it's being, it's saved all the way until the end. But we're kind of landing on this compromised middle ground where we're setting it as a Q4, right? And the goal here is, again, to reduce the burden of the computer burden of charting that you guys are having to complete on a daily basis. I want to try and make your documentation as efficient as I possibly can so that the majority of your time you can spend in a patient's room doing education and patient care and not being tied down for hours on end trying to plug stuff into the computer, right? So anywhere that you see opportunities for us to continue to improve that, please convey that to me. I'm also working with the physicians on improving their order sets. I'm working on making some adjustments to the order sets that we already have in the system. So like pick lines, Foley's, things of that nature to make it a little more consistent. So it's just one click of a button and it gets you everything that you need. So please, when you see those opportunities, if there's efficiencies that can be improved upon, especially where you're having to click through, a lot of different boxes and a lot of different screens in order to complete something, that's what I want to try and cut down on as much as I can to improve our efficiency when it comes to documentation. The ADL stuff is just one of those aspects that I'm currently working on. We've already covered end of shift expectations in our conversation earlier. So I'm going to tie the equipment and the environment stuff into the next slide with the upcoming summer season content. So in the meantime, same thing as always, we are consistently tracking attendance for all staff members per the hospital policy. If you don't know the policy, if you're not familiar with the policy for attendance with the hospital, I highly encourage reach out to me. I will send you a copy of it. I'm happy to share that with you. So a couple things I want to cover clear here. Three occurrences within 3 months, 4 occurrences within 6 months is the policy as it stands. Target count as half of an occurrence. If you are having complicated medical issues, it is on you to pursue garnering FMLA support through your provider, right, in order to cover your absences in regards to the medical condition that you are facing, right? So if you are anticipating that you are needing to be out for an extended period, whether it is surgical related, maternal related, what have you, it is critical that you ensure that you complete the appropriate documentation so that stuff is covered, right? Outside of that, right, as I have always stated, my expectation is that when people are supposed to be here, that you're here. However, I do not want you here if you are sick, right? The kicker with the sick component is there is a big difference between somebody having the flu and being out for a week, which counts as one occurrence, right? versus someone that is, needing surgery or has a complicated medical issue for which they're having to go back and forth to the doctor multiple times, right? That's where it is prudent for you to ensure that you have your FMLA paperwork filled out so that your absences are covered, right? And so that you can appropriately plan ahead for your doctor's appointments and things of that nature, right? Because that covers you in that regard. So the standard expectation is 3 shifts a week. It's understandable. People are going to get sick. People are going to have bereavement leave reasons that they need to go out for. Folks, need time off from time to time. I highly encourage. As always, I do not deny PTO. Our upcoming, I believe it's March 21st, Cheryl, is our cutoff window for PTO requests for the next schedule period. I think that's what it is. So the kicker there is if you get your PTO request in before that March 21st cutoff, I will approve your PTO, guaranteed. Whatever it is for, whatever duration of time it's for, I will approve your time off for that period of time. Once the schedule has been built and posted, however, and your shifts have already been plugged in, right? If you have time off that you need that's coming up, that's where I now need you to coordinate with your team members, right, to ensure that your shifts are getting covered, right? Because this is now no longer a planned time away from work, right? This is an unplanned time away from work. Okay. And now you are shifting the burden of your shift coverage onto your teammates, right? So whereas if I'm able to have the time ahead of time to plan for it, right, I can ensure that the shifts are covered and the PTO is easily approved, right? So please just ensure with the upcoming schedule sign up period, right, you have until the 21st to get your PTO requests in for the time period covering from April 12th going out to it's like June 13th, I believe, somewhere around there, the first or second week of June. So get in there, get your time off requests put in, so that way we can get those appropriately built into the schedule. And then same thing as always, I consistently cover this since we've made the modification, and I'm probably going to keep this in rotation so that we consistently capture people. Anytime you have any time card issues of any type, I need you to send what the issue is to me in an email. If you do not email it to me, there is a very good chance that I will forget. If you text it to me, your texts, I get probably anywhere from 50 to 100 text messages from different people a day. So there's a very good chance that your text message is going to go to the bottom of my thread for texts. And I may or might not remember to go in there and check when I'm doing time cards. If you tell me when you're walking through in the hallway, right, I have multiple things that are pulling me in different directions that I may well forget exactly what you told me or forget that the conversation even happened. Whereas if you send it to me in an email, I will not forget to make the adjustments to your time cards. So please, if there's something that you need modified, Tristan sent something to me via email yesterday, right? It makes it easy for me to go in. I keep it in there. That's my task list. I usually have less than 15 emails active in my inbox at any given time. So that way I can consistently make sure that as I complete what it is that you're requesting for your time card, now I can file that and I know that it's taken care of. So I want to make sure that I'm getting your time appropriately adjusted and appropriately represented for you guys. So please, email is key there when it comes to time card adjustments. Last thing that I want to cover, we are coming up to the summer season. We're currently in the second week of March. It's somewhere around the second or third week of April that we typically see our cliffs show up. As it stands right now, we already have a planned down staff with contract labor going into the month of April. So as of April 1st, we will be reducing our overall contract labor by a total of 5 members. And that is with intention, because our census during the middle of April typically drops from an average daily census of 12 to 14 down to an average daily census of 6 to 8. Right? As a consequence, right? We now start to encounter the flip side of what we see during the winter time, right? Typically during the winter, I'm asking people to pick up, work a little bit extra, do some extra, right? Versus the summertime is where we typically encounter on-call stuff. So I wanted to address this ahead of time. Summertime is our gearing up period. It's our opportunity to ensure that we are ready to go come, right? And so as we start to see census slowly decline, right, I want to ensure that opportunities are being provided to staff members so that they can continue to come in and get their, right? I want us to take this summer period that we're coming into very seriously in regards to gearing up for the winter season, this coming winter, season that starts, September, October, later this year. We have opportunities here to, if you don't know how to do chart audits, to get trained to do chart audits, so you can come in and assist with chart audits. If you know how to do them, you can come in and do them. If you are an organization type person, I want to ensure that every bed, every chair, every suction canister, all of our walls, all of our outlets, every light switch, just like we did last year, going through and checking to see, are there opportunities that we can make patch repairs, paint repairs, sending beds for repairs, checking our vital signs machines, checking our draggers in the ICU. Anything that we come in contact with and touch and use on a day-to-day basis, I want us to have the opportunity to check it and ensure that it is functioning as intended. If it is not, I want to make sure that we have an opportunity to get it labeled and fixed before we go into the next winter season. Right. So for my charge nurses, this is one of the lowest hanging fruit opportunities for when we have staff that are otherwise going to be placed on call to come in and have an opportunity to check and test these items. Now, as we go through and start to check these things off the list, there's going to be other opportunities that we're going to have to come up with. And trust me, we are going to get very creative going into the summer season to ensure that people are still having an opportunity to get their hours. I want this department to be looking and functioning like it's been brand new, refreshed when we go into the winter season. Testing our Hoyer lift batteries, anything that you touch and or use on any given shift, right? I want to ensure that we have an opportunity to clean it up, fix it up, and have it in tip-top shape when it comes to that time of the year. So chart audits is another option. And then we also have some upskilling that's going to be made available for nursing staff for the summer season as well. That includes heading down to either Onvita Health down in Yuma, heading up to Havasu to basically go and work some shifts over in those hospitals on higher acuity units where you can be able to explore and see more complicated patients and workflows, right? And then bring that information back with you when you come back to the organization here. We are also still working towards bringing in the sim lab as well. And so basically what we're looking at doing there, what I kind of dream and imagine, I've been thinking about this for the last 2 years, is having basically a combined didactic and hands-on course where we can actually pull staff off of the schedule for basically a full week and take anywhere from 3 to 4 members over to that education area. And whether I'm doing the instruction or we have multiple instructors to go through didactic content and then also use the sim lab to do practice scenarios from everything from RSIs to a patient that just fell and has a head injury or has a hip injury, to patients that are coding, to patients that are needing sedation because they're becoming violent, to recognizing critical conditions. You name it, we're going to be hitting these topics and we're going to be doing them in the sim lab. My goal here is to make these scenarios as difficult as we possibly can, and to ask and challenge the attendees in any way possible to ensure that we're able to explore every possible avenue and algorithmic direction, right, that a patient could potentially go, constantly throwing in twists and turns and unexpected events, right? So that way, when you guys are exposed to this stuff in the department, it's not necessarily the first time that you have run into it and seen it, right? We'll be doing everything from, intubating patients, to even doing things like placing central lines or art lines, right? Anything that we can to be able to upskill you guys over the summer when our census is typically lower and we have a tendency to see on call. I want to take advantage of that opportunity, so that way we can not only increase our skills and ensure that our equipment is in good standing and order, but just kind of overall level up our team before we go into the next winter season. So we're right on the cusp here of being able to really, um, bring our entire team to that next level of operation and function. And yes, every single person is going to rotate through every role during those training sessions. So if you historically are not a person that is a leader in a room, you're going to complete that task as well. And the goal there is so that you better understand what the leader is expected of during that time too. So, questions on any of that content that I just covered, suggestions, anything like that? And yes, I'm going to need help making lesson plans and all of that for that training as well. So anybody that is, has taught before, or is currently teaching or currently going through a schooling program that wants to get involved. I don't know if it's something that you could, use as a capstone project or, anything of that nature, but or maybe, long term you're planning on going into, nurse education. This is a good opportunity to get involved in that kind of work. So that way you can kind of either start cutting your teeth or, reintroduce yourself to education if it's been a while. And just because I'm not going to be able to do it all by myself, right? I'm generally not going to be able to do it by myself. So I'm going to need folks that want to teach. I'm going to need folks that want to instruct at the bedside when we're doing the sim stuff too. So yes, ma'am. Miss Krista?
Sorry, I accidentally pressed it.
Oh, you did nothing to add, my dear?
Nope, sorry.
You're good. All right, anything anybody else has questions about, wants to cover before we conclude?
The text I sent you?
Cleanliness.
Yes.
So, one of the things that I have done myself when I have worked as charge in the last month or two is towards the end of the shift, and this is days or nights, but particularly on days because we tend to generate, at least from what I've seen, we tend to generate a decent amount of waste on day shift, and that's just circumstance of we have a lot of moving parts during the daytime of additional staff that's in house that is using all of the equipment and supplies that we have available. We tend to produce a lot more waste on days. So the kind of the key focus here is towards the end of your shifts, 4 or 5 o'clock in the afternoon. It is critical that we ensure that we are going through and being good stewards of the areas that we're working in. So one of the steps that I take towards the end of the shift on days is around 4 or 5. Myself and the ward clerk will go through and, any stray sticky notes, stray paperwork, boxes of donuts, what have you, that is sitting out in the nurses station. We will, as a concerted effort, go through and eliminate as much of that as we possibly can to generally just clean up the area and ensure that it is looking as prepared as possible for the next shift to come on. And that same kind of mantra, I want to ensure that we're consistently practicing in our patient rooms as well, right? That kind of wind down portion of the day, med passes have been completed. You're maybe taking an opportunity to put some last minute final touches on your documentation, right? have your lunch sitting out in the lunchroom, or you have something sitting in the fridge. This is an opportunity for you to go through and clean up after yourself as the next shift is coming on. So this doesn't just stick with just the patient rooms. It includes the patient rooms, it includes the nurse's station, and it especially includes the break room. So obviously you are welcome and encouraged to bring in your own lunch and your own food, your own containers and everything, right? But the key here is just ensure that at the end of your shift, especially if it's your last day of the week, go through the fridge, pull out whatever it is that you brought, right? And take it home with you, or toss it in the trash can at a minimum. At the end of your shift, towards the end of the day, go through your patient rooms. Lately we've been seeing teams of 3 or 4 patients. So it's not a lot of rooms that you have to go through and check, and just do a once over in there. Take a look at the linen in bin. If it's full, take it out. If the trash is full, take it out. This isn't just only the techs are responsible kind of situation. This is something that as a concerted effort for every team on every shift, that we can go through and ensure that we've done our due diligence and ensured that we're practicing good stewardship for the next shift coming on. It's one of the easiest things to keep people happy going from one shift to the next. It's also one of the easiest things to piss people off, right? So please make sure that you are being cordial and practicing good stewardship, cleaning up either as you go or prior to leaving towards the end of the day. It's very easy to accomplish. And if it is not accomplished, it's very easy to set people off on the oncoming shift, right? Because now their workstation, the first thing they're having to do is clean up their workstation, or clean up some trash that's in the break room, right? So let's take care of that for the next oncoming shift. It just helps to push things over the edge, right? As far as setting your next team up for success, right? And you want to talk about an easy way to build good relationships with other shifts is ensuring that those workstations are clean and ready to go. So, anything else anybody has before we convene for the weekend?
Yeah, Keenan, I do have a question about the Voceras. Are we gonna do a checkout and check back in per shift like we did at HRMC?
We will come up with some kind of a process, whether we're keeping them. And I've seen it done a lot of different ways. Some facilities keep
Yeah.
them in the Pyxis. Some facilities just assign a Vocera to a staff member. I don't think we quite have the quantity of Voceras to assign one to every person. Obviously, we also have the batteries, which, as you know, the batteries for those over a course of 6 months to a year, they start to break down,
Yeah.
the little clasp on them and whatnot. So we'll come up with some kind of a checkout for those, so that we can ensure that we aren't losing them or ending up with a significant number of them missing. I can definitely say that was one of the reoccurring challenges that I ran into in Havasu when we had Voceras, is that they would go missing. They're really easy to take home. They're really
Yeah.
easy for people to keep on their person. They get to their car and they're like, oh shit, I took another Vocera home. Then they set it down with the 2 other Voceras that they have sitting in their car, right? It's super easy thing to accidentally do. There will be there is a tracking process that those servers have, that basically tracks based off of the last person that logged into the Vocera. So if one does go missing, so they'll all be numbered, labeled, and all that. It's an easy report that we can run and identify whoever the last person was that had it. So it makes it easier for us to reach out if it's missing. And then on top of that too, I think the other benefit for us as well is that we're not quite as large of an institution, right? So it's going to be a little bit easier to keep track of all of these Voceras that are going to be in circulation. But yes, we will have some type of checkout process in place,
Okay.
so that we can ensure that these doodads don't go missing. So,
Okay. Yeah, I figured it
all
might be
right.
something that just added to the black book, like the PC book. Okay, cool. Thanks.
Yep. All right, everybody, enjoy your weekend. I'll get this posted here in within the next hour. So for anybody that wasn't able to attend on the call, they'll be able to access it, same as we always do. I'll post it on YouTube so people can watch through. Take care, and thank you for kicking ass on all of the infection prevention stuff that Trish shared. Keep it up. Keep up the good work. Let's keep it going.
All right, thanks. Have a good weekend.
Congratulations, Cheryl. Are we official?
Oh, no, not yet.
Oh man, is she
Yeah.
home or is she still in the hospital?
Oh, she's not going to the hospital. She's doing home birth.
Oh boy.